Welcome to the University of Colorado School of Medicine's Ask an Expert with Dr. Ken Tyler.
Well, first of all, I want to emphasize, as you can see probably from the background, that I'm doing this from home. So social and physical distancing is something that we not only talk about during this, but I hope all of us like you who are also doing this from your house, are practicing as well. To introduce myself, I've been at the University of Colorado's medical school for over 20 years. My interest is in neurology as a clinical subspecialty, but infections of the nervous system more particularly, and probably especially viral infections. And that's been both a clinical interest of mine, but a basic research interest as well. And so, we have studied everything from sort of experimental model viruses to more common things like West Nile and even Japanese encephalitis and others. So I'm a little bit here probably as a sheep in wolf's clothing because COVID-19 disease, as and most of your listeners know, is predominantly a pulmonary rather than a directly neurologic disease, but it does have neurologic impact and consequences.
What are the neurological consequences of COVID-19?
I think it may be helpful to kind of think about them in three broad boxes, but to remember that literally every day, like you, I'm going on the web, and where it's a whole new world in terms of things you said on Monday, you suddenly realize were wrong on Tuesday. But I guess I would have said a few things. The first is, and perhaps not surprisingly, that we're seeing the indirect pulmonary and multi-organ systemic processes related to COVID-19. And I would include in those also the complications of things like disseminated intravascular coagulation or other things that can promote clotting. And so many of the early studies, including some of the first ones out from Wuhan, where they tended to focus on the more severely ill patients. So the kind of first neurologic studies tended to start with patients who were already in the hospital, and in many cases, fairly severely ill, meaning they were in an ICU, they were often mechanically ventilated, the mortality rate was quite high. So you're, of course, starting with the what are we seeing in the more severe affected patients. And I think two of the things that came out of that was that it was clear we would see altered mental states and encephalopathy, that we saw an increased risk of various types of cerebrovascular disease, meaning stroke, probably both ischemic and hemorrhagic, and that those were kind of two of the important pieces. So I think just like any systemic infection that might compromise organs, and produce either metabolic or other consequences, we're going to see those kind of neurologic complications. And in fact, they've already been reported. I think the second issue, which gets a little more interesting, is will we see evidence of direct virus infection of the nervous system and injury to the brain, and think encephalitis or meningoencephalitis, or in the spinal cord, myelitis. And we know from the prior experience with MERS and SARS-1 that those kind of things could happen, but they were relatively rare and relatively unusual. So there were cases where patients would have evidence of, for example, encephalitis, in which they either, if they died, one could find the virus in the brain, or if one did RT-PCR and spinal fluid, one could detect the virus. Now, so far, there haven't really been convincing reports in the peer-reviewed published literature suggesting that that's happening with COVID-19. Now, the number of cases in which patients have had things like altered mental status and people have examined the spinal fluid and been able to do RT-PCR is very limited. But so far, I'm not aware of positive cases. But I would have said we saw encephalitis, we saw rare reports of brainstem forms of encephalitis with this, and we know that other non-human coronaviruses can be directly neurotropic, whether that's things like mouse hepatitis virus or porcine gastroenteritis virus or others. So the potential is there. And then I guess I would have said the third box is there was some suggestion that, and we know this from other viruses, that you can get what I would call post-viral immune mediated processes. And there were reports of things like acute disseminated encephalomyelitis, which is a demyelinating disease that can be triggered at times by viral infections. And those were reported with SARS and with MERS, as were things like Guillain-Barré syndrome, an acute inflammatory polyneuropathy, now something affecting the peripheral nervous system. And so, again, I think we're going to need to be on the lookout for those kind of things. And in a sense, maybe a little bit the analogy might be to Zika, where, first we saw some of the effects of direct viral infection, like the microcephaly and the congenital Zika syndrome. And then it was subsequently realized, you could see things like Guillain-Barré and other manifestations. So I think we'll have to keep our eyes out for this. We've all had kind of anecdotal reports that suggest that it's possible that this is something that could occur. So I guess I would have said for me, those are my three big boxes: the indirect effects of the damage on other organ systems, which would tend to occur in the most severely infected patients; the query as to whether or not we'll see things that suggest direct SARS-2 invasion of the nervous system and what they'll look like; and then the possibility that you might see post-viral immunologically mediated things. And so to me, those would be the kind of boxes I would think about the neurology of this in.
What about the potential for transsynaptic spread?
That's a great question. One of the interesting things that sort of started to come out of the ENT literature, but has been in a number of the other studies as well, is, there's a subset of patients who seem to lose smell and taste, and there's still some debate as to whether the taste loss is a primary phenomena, or as and I know and your listeners would know, if you get a cold and you lose your sense of smell, it dramatically affects the way you appreciate tastes and things. And I think the interesting thing that we're still waiting more data on is how common is this? So in the original papers from Wuhan, which were, as I say, fairly sick patients, probably the incidence was less than 10%. But some of the more recent studies from Europe and elsewhere have suggested that number may be considerably higher. And then, of course, the really interesting questions are, is it early? And is it something that's specific? Again, we all know that if you get a cold or an upper respiratory infection, and many of these are co-circulating, including influenza, that these kind of things might occur. And the question is it more distinctive, more common with COVID? And I don't think we know yet. People have proposed things, including, really doing a smell test, because that's an easy one to do, even as a screening test, the same way we're looking for people, do you have a fever or not a fever? And I think the mechanism of that isn't clear to me. This virus tends to infect cells by using the angiotensin converting enzyme 2 receptor. And that doesn't appear to be present on olfactory neurons. So it doesn't seem to be something as common as you just infect those neurons and kill them. And most of the reports that I've seen, again, although this is subject to change, suggest it's a transient phenomena, meaning people seem to recover their sense of taste and smell as they recover from the infection, which would also argue against something that causes an irreversible injury. We don't honestly know about your question, so I dodged it a little bit of transneuronal spread. But some of the studies done by people like Stanley Perlman at the University of Iowa and others on coronaviruses, not specifically the human coronaviruses, but with mouse and other coronaviruses, have suggested that these viruses do have the potential to spread between neurons and to enter the nervous system, potentially through olfactory routes. So, whether or not that's applicable or has any role in the pathogenesis of COVID-19 disease remains to be determined. Some people have even speculated that some of the mechanisms behind respiratory impairment could theoretically be due to spread of the virus to respiratory centers in the brainstem. Again, that's theoretical, not actual. And I think most of the evidence would suggest it's an ARDS mechanism with either, especially a hyperinflammatory ARDS, mechanism among the subsets of those things.
What about viremic spread through endothelial cells?
I'm not sure I know the answer to the question, except to say that one of the things people have talked about when they talk about the vascular components of COVID has been whether or not endotheliopathy could play a role in this. So I think that's not clear yet. What we do know is it does look like there's an increased risk of, say, stroke and vascular disease, but I'm not sure we know what the mechanism is. And I might also have said that we know that a number of cytokines, many of which in the more severely ill infections are increased, can influence things like the integrity of the blood-brain barrier and other things. And so, again, whether there might be indirect effects on endothelial cells, and the blood-brain barrier through cytokines or other things like that, could be an issue. But beyond that, I think I honestly don't know.
What subgroups of neurology patients are at higher risk for severe disease?
So I think one of the things we've sort of learned so far is that the risk factors that seem to be emerging just in the general population is the older you are, the higher the risk is that you'll have a severe infection, meaning an infection that will likely lead to your being hospitalized or potentially even dying. So if you look both at our local Colorado data, the national data, or the international data, those risks climb directly with increasing age. Interestingly, in a number of studies, and I think this has again also been true in the Colorado data so far, for reasons we don't understand, males may be at increased risk of serious infection compared to females. And then I think another thing that, of course, has been getting tremendous attention recently, but that the data is even sparser on, is whether there might be racial or other disparities in healthcare outcomes and whether or not those are due to things like access to healthcare, other comorbidities that may be more common in different populations. I think we also know that comorbidities, meaning other diseases, including things like diabetes, hypertension, heart disease, immunosuppression, all increase your risk. So if you imagine many neurologic patients, of course, not all, but many of them are in an older age spectrum. So for many of our neurodegenerative diseases, those affect older patients. Patients who we see with stroke or vascular disease often will have other risk factors like heart disease, diabetes, hypertension that are risk factors for this disease. And so all of those comorbidities, I think, are to some extent enriched in some of our patients. And then, of course, you have the neurologic diseases that put you at risk because, for example, they compromise your pulmonary function. So if you have motor neuron disease, if you have myasthenia gravis, if you have things like that, you may have a compromised pulmonary function to begin with. And so do patients with Parkinson's disease and other neurodegenerative diseases. So if you get a pneumonia or a respiratory infection, your pulmonary reserve and capacity could be much less, and that would put you at increased risk. And then finally, although they used to always tease us when I started my training that neurology was a specialty of diagnose and adios, meaning that you made an occult diagnosis for which there was no treatment. Now we have tons of different treatments, and a big component of those that have really exploded are, of course, immunomodulatory treatments. So many of our patients, whether they're those with autoimmune infections, with myasthenia gravis, with uh, multiple sclerosis, you name it, peripheral nerve diseases, are receiving immunomodulatory therapies. And I think another population we believe to be quite vulnerable is those with a compromised immune system. And I think we don't yet know. Many of those drugs target different arms of the immune system. Some go after the antibody response, some after the T cell response, some even target cytokines. And I don't think we yet know if the risk of all of those is equivalent or not. And I think that's one of the things, we'll have to learn. So I would have said, those would be some of the groups I would have thought about that are, at particular risk.
How are you keeping busy during self-isolation?
My dogs are abundantly walked and groomed and have probably never looked better. I watch the clock every day for 5 o'clock for cocktail hour, and my wife and I have gotten very good at mixing our own drinks and things like that. I even made some homemade vermouth the other day so we could have our Negronis or Manhattans. And I think we've been busy around the house, doing everything from clean a room a day to looking at reinvigorating old hobbies and things like that. So I think, we all do whatever we can to, kind of keep busy. And as I said before, I think we're very respectful of the social, distancing and other things because to some extent, you lead by example. And so we're trying to be very good about keeping sane, but not going to the grocery store or going, violating any of the things that we can possibly do to keep healthy. And we've been enjoying using Skype and Facebook, FaceTime and other things to keep in touch with people.